I'm a consultant urological surgeon and I work at University College Hospital London in the United Kingdom. My whole practice are men who are having problems with bladder symptoms or incontinence. Men can have problems with narrowing, scarring when the prostate is taken out and the bladder is joined back to the water pipe. That joint can narrow down and give you what we call medically a stricture, but it's a scar and a narrowing. And that can cause problems with bladder emptying, poor flow, having to strain and push when you go to the toilet to pass urine, going to the toilet more often than you would like, more often than the man next to you. Radiation therapy can also be associated with strictures. Long-term radiotherapy, whilst it cures cancer, can be associated with a chronic loss of blood supply to the bladder, and that can result in the bladder becoming less stretchy, less distensible. There are men who've got disabling frequency urgency. They're going every sort of 40 minutes to 2 hours. They're getting up at night to pass urine. And then you have to tease out what's the cause of that underlying problem. When the bladder fills, it should sort of stay a nice low pressure until you get about half a litre into the bladder. And then you get the signal saying you need to go to the toilet. You get a slight rise in your bladder pressure. You go to the toilet, the bladder pressure rises, the muscle that keeps you dry relaxes, and you pass urine. But if you've had your prostate removed, it can alter the way the bladder behaves. And so the bladder, instead of staying nice and stable and low pressure, can have peaks of pressure. And that can be associated with a feeling that you've really got to go to the toilet. And if you try to hold off going to the toilet, then you can leak. And that's called overactivity-related incontinence or urge incontinence or urgency incontinence. In terms of treatment, well, first of all, there's the simple things. There's the self-help things. So self-help could be, look at how much you're drinking. It's very fashionable at the moment for all of the magazines and the health magazines to tell everybody that you need to drink lots and lots. The solution to pollution is dilution, and that will detox you and make you better. But actually, we're designed to function at a set level of fluid intake. And that's normally about 1.5 litres a day, plus or minus, more in hot weather, more if you're particularly physically active. And anything that you drink more than that, 1.5 litres, 3 pints, then will come out and you'll go to the toilet a lot more often. So first of all, look at how much you're drinking. Secondly, look at what you're eating, what your diet is. If you're eating a lot of fruit, there's a lot of water in fruit as well. So that can make you go to the toilet more. Treatment that our physiotherapists offer for overactivity, frequency urgency incontinence it's called bladder training. And it's basically keeping a note of how often you're passing urine. I'm going every 2 hours. I'd like to go every 4 hours. So next week, I'm going to hold on for 5 minutes each time I feel the urge to go to the toilet. I'll maybe do that big pelvic floor contraction, but I'll hold on for 5 minutes. I'll distract myself. I'll write a shopping list. I'll think about something. And then about a week or two later, I'll hold on for another 5 minutes. And gradually it's been shown that you can extend the time between having to pass urine, and it's called bladder training. The next step up, see your family doctor, and they can start treating you with some tablets. There's 2 different types of tablets. The major group of drugs is called antimuscarinics, and what they do is they block the transmitter, the nerve transmitter that makes the bladder contract. So they block the stimulus to contract, which is a bit overactive if you've got an overactive bladder. There are many types of antimuscarinics or anticholinergic drugs on the market. The oldest one and the cheapest one is called oxybutynin. And then there are other more modern ones that are more selective, that have less side effects, tolterodine and solifenacin. But then there are other tablets called darafenacin. And if you're worried about a possible association of this type of drug with dementia, then trospium is probably a drug to think about. And you take them once a day, the extended relief version, or maybe twice a day. And you have to keep taking them. They take about 2 to 3 weeks before you notice a benefit. And then you should notice that the amount of times that you have to go to the toilet to pass urine, the urgency reduces significantly. The side effects that can be associated with these drugs are that you can get a dry mouth. It's more common in oxybutynin, which is the oldest and cheapest version, and it's less common with the more modern drugs that are more expensive. If you're worried about dementia, or if you get a side effect like the dry mouth or the constipation, is a drug called a beta agonist. And what it does is it excites the receptors in the bladder to cause the bladder to relax. It works in a different manner. And there's only one drug currently on the market. Its drug name is mirabegron. It's available in all of the countries as well, but it's because it's modern, it's still under patent, so it's relatively expensive, but not as expensive as more of the more invasive treatments that we'll talk about later. And again, it's a once a daily dose. There's relatively few side effects. They do recommend that you have your blood pressure checked before you start it, because it may be associated with a slight increase in your blood pressure, not enough to make you hypertensive. I've got some pictures that I can put up to show if it makes it easier for people to understand what I'm talking about. So if you don't get the response you like, or you get a significant side effect with the tablet treatment and you're still very bothered by your frequency, urgency, urge incontinence, you then move on to what we call second line treatment. And you've got a choice of treatments. And basically, you need to decide what treatment suits you best in terms of the way you live your life, your tolerance of side effects, and the kind of whether you want to have something that is very effective, but you have to keep going back to the doctor, or you want to have something that may be effective for a longer period, or whether you'd like to pursue a more natural type of treatment. So your options boil down to injections of botulinum toxin, Botox, into the bladder. So the injections that get rid of sort of all the wrinkles and the cosmesis. If you inject them into the bladder, which can be done just as an outpatient office procedure under local anaesthetic, then you've got about a 70% chance of getting rid of the frequency, urgency, urge incontinence. It lasts on average for about 6 to 8 months. The main side effect is that about 5 to 10% of people will have difficulty emptying their bladders afterwards. So it goes from emptying too much and too frequently to being a little bit lazy. And they may have to self-catheterize, pass a tube into their bladder through their water pipe to empty their bladder maybe once a day, maybe twice a day, if they're very unlucky every time they wee. But the vast majority of people, 95%, don't have a problem. So that's one option. Another option, and again, that can continue for as long as you like. We've got some people who've been coming for the last sort of 15 years to UCLH, where I work, having their repeat Botox every sort of 6 to 8 months with continued benefit. If that doesn't appeal to you, if you're more into the holistic type of practice, you could try acupuncture. So acupuncture works as a form of neuromodulation. Neuromodulation is a fancy word, and the best way to explain it to people is, you know how if you bang your elbow, it hurts, and you rub it, it gets better? What you're doing is when you bang it, you're getting pain signals going to your brain saying it hurts, it hurts, it hurts. And when you rub it, because there's only so many motorways or highways to the brain, when you rub it, you're using some of those highways to take the sensation of touch to your brain, and therefore the pain is reduced because it can't travel up. So that's what neuromodulation is. And so with acupuncture, with percutaneous tibial nerve stimulation, PTNS, which is another type of neuromodulation, and with implantable neuromodulation or sacral neuromodulation, they all work in a similar manner. They send signals by either electrical impulses or the needle impulse or a combination of both to the brain, and they reduce the amount of signals that the brain is receiving from the bladder, which say squeeze, 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 and therefore calm it down. So this is a long-term implantable device. There are 2 manufacturers who make this type of device on the market. There's Medtronic, And then there's another one that I'll show you from a firm called Axonics, and you may be offered either or both. Your insurer may tell you what to do, what you should have. And there's two different ways you can have it. So if you look at this diagram, what happens is it's an office procedure, and you can, if you see in this picture, can you see this picture?
Yes.
Fantastic. So you can see that there's a little needle put through into the tailbone, the sacrum, while the man's awake, under some local anaesthetic. And you can either put a needle that you take the pointy bit out and you leave a wire, that you pass a wire through, and you tape it to the skin, and you can attach it to an external battery for a test period of 4 weeks, because it's a very expensive device. It works in about 70% of patients, and you don't want people to have to pay for the whole of the device when the battery's the expensive bit if it's not going to work for them, and the health system doesn't want to pay for it if it's not going to work for the patient. So you do a test period, and that can be done in two ways: a local anaesthetic, peripheral nerve evaluation, which is done under local in the office, and they'll ask you if you can feel various changes in sensation. And when they put the needle in, then they thread a wire in and attach it to a bit of electricity and see if you can feel the sensation in various parts. Sometimes you have a big bottom held in front of you, a sort of plastic bottom, to point out where you can feel the sensation. Or you can have a more permanent lead put in, a tined lead, under general anaesthetic. And that has the advantage in that you can use that tined lead long term. If you have the simple peripheral nerve evaluation, if it works for you, you normally go away for 2 to 4 weeks and see how your symptoms are. And you keep a little diary. And if you're going less often, if you're leaking less often, when you come back after 2 to 4 weeks, they would take that needle out just in the office and list you to have a full implant. Or if you have the more permanent lead, the tined lead put in under general anaesthetic, if it's worked for you at the end of 4 weeks, then they take out the extension through the skin. So the tined lead is guided down with X-ray guidance, and then it's buried and it's brought out through the skin with an extension and connected to an external battery. The peripheral nerve evaluation lead is also connected to an external battery, and you can change it. You can turn the power up and down and turn your stimulation, change your stimulation. There's often your clinician, your urologist, or your urologist nurse practitioner, specialist nurse will help you with that. If there are problems, if you're not getting the benefit you'd like, you can have a telephone consultation with them and you can make some changes. And if it's worked for you after the 2 to 4 week test period, then what happens is that you have a permanent needle put in through the hole in the sacrum, the S3 foramina. It just means the hole, the third one down. And you check for special reflexes, and then it's buried and it's attached to a battery. Now, this battery is made of titanium in all three of the devices, and it comes in two forms, and it really depends on the type of person you are. So there's a bigger battery, which is only made from Medtronic, and that lasts for about 5 years. So you put it in, it's working for you, and it lasts for about 5 years. And when it runs out of steam, you have to go back, have another little operation to change the battery. So if you're the sort of person, I think I'd be that kind of person that wants to have something done and then wants to forget about it and get on with life, then that's what you would want. But there are other people who prefer to have a bit more control, or would maybe like to have a device that would last longer. So this little battery here and the battery from the Axonics device, they both work in the same way. They're rechargeable. So you have to remember every week, every 2 weeks, to put an external charging belt on. So just like your phone, you plug your charging belt into the wall, and then every 1 to 2 weeks, you wear it over where the battery sits in the fatty part just above your buttock, and you charge the battery. And then that should last for 15 years. And you should reduce the number of changes you have, but you have to remember to charge it every 1 to 2 weeks. There's the ability to change some of the settings to optimize the benefit in terms of frequency, urgency. It's 2 relatively simple day case procedures to put a tine lead in, or an office procedure to put it in. And then it's another day case procedure to put the whole device or to complete the device implantation. You can now have MRIs with it. So it used to be that you couldn't. And the main risks are that, apart from that it doesn't work in 30%, the device can get infected. And if it gets infected, it has to be taken out, as it doesn't tend to respond to treatments. Another type of neuromodulation is this that you can see here, and that's called PTNS, which stands for percutaneous tibial nerve stimulation. So if you stick an acupuncture needle into the area just behind the ankle on the inside of your leg, then we call that the medial malleolus, and stimulate it with a little bit of electricity. It's a form of electroacupuncture. And interestingly, the nerve supply to this area of the leg comes from the same part of the spinal cord as the nerves that supply the bladder. And so by stimulating that highway, you're managing to reduce the sensations to have to go and to have to pass urine frequently and urgently. Now, this isn't a one-off. This is something that you have to attend every week for 12 separate sessions. And that'll take 45 minutes to an hour of your time in the office once every 12 weeks. And if it works for you, and it works in about 60 to 70% of people, you can then have a top up, which is a course of 3 weekly injections every 3 months. We have group therapy sessions with people all sitting, well, we did before COVID. We're now getting them set up a bit like a hairdresser's with the plastic screens between. So it's not as nice as it used to be, but you can have little group sessions of these to reduce cost and increase sociability. And we're now thinking of trying to show people, if they're interested, in how to do this themselves, so they could either purchase the box or they could borrow the box, like from a library, to do their top-up sessions if it's worked for them. And then the final thing you can have, we talked about acupuncture. That's not that has evidence again for about a 60% benefit. Same thing, you'd have to go for 12 weekly sessions, and you'd have to have top-up sessions. There are some doctors who do acupuncture, but that would mostly be with an alternative therapist. We've got a British Medical Acupuncture Society. And more experimentally, coming ahead, for those people who don't have the time to come once a week for 12 weeks to have the PTNS, there are some new implantable devices being tested, hopefully for the market in the next year or two, where you implant a little coin or a little receptor in that area where that acupuncture needle went in, and then it's charged with an ankle bracelet, which looks a little bit like a criminal, but it's not. And you do that once a week, and then it continues to work for you without you having to go into the hospital. So they're the 3 different types of sacral neuromodulation that we've got. Well, if the sacral neuromodulation doesn't work for you, you can try Botox, which is, like I say, office injections into the bladder. And if Botox doesn't work for you, you can try neuromodulation. But if one of the neuromodulation techniques, say if PTNS doesn't work for you, then it's unlikely that sacral neuromodulation would work for you, because it's just not going to work. So if you don't get any joy from those second line treatments, then the third line treatments are much more invasive, and they're all proper operations, surgical invasive operations. So if those don't work for you, the next recommended treatment is what we call a clam cystoplasty. We call it a clam because you split the bladder. This is a diagram of a cut in a tummy. This is the front wall of the bladder. This is the back wall, and we've divided it in 2 to open it up like a clam. Yeah. And then you have to take a loop of small bowel, like a sausage from your small bowel, and keep it on its blood supply, open it up, and then you put it in to the bladder to enlarge it, to act like a shock absorber. I don't know if you have these, we have these ice creams on the beach, which we normally have in the rain in Britain because the weather's never that nice. and you have your cornet, and then the ice cream in the middle. And that's a clam ice cream. And this is what you're making with the bowel to enlarge and stop the bladder from squeezing all of the time. And so when you put it all back together, you've got a much bigger, baggier bladder that doesn't contract as much. That can be done through a cut on the tummy, a bikini line cut, like ladies have when they have cesarean sections. Or if you've not had anything other than your prostatectomy, it could be done using a robot. You can do it robotically. So you swap one longish scar for about 4 or 5 little scars. But you may get better. You may be able to leave the hospital quicker. The advantages of this are that about 85 to 95% of men or women, if they're having it done for the same sort of thing, will have cure or significant improvement of their frequency, urgency, urge incontinence. The disadvantages are it's a bigger operation. It carries all the inherent risks of surgery, so the general risks of having an anaesthetic, chest infection, wound infection, blood clots on the legs that can go to the lungs, bleeding that may need a transfusion. All of those are low risk, less than about 2 in 100. It carries acute risks of having a leak from where you've taken the bowel that can make you quite sick, and you might have to go back to surgery for an emergency. Again, that's pretty rare if you've not had any previous surgery. And sometimes if you handle bowel, your own gut just doesn't work for a little while, and you have to be supported with fluid into your veins and occasionally food into your veins. But again, that's fairly rare. Long term, about 20% of men who have clam cystoplasties will notice they get problems with recurrent urinary tract infections. About 5% of them may have problems with stones. And an increasing number will have to pass a catheter up their own penis to empty their urine. We call that intermittent self-catheterization with time. It's about 50% will have to do that. So it's the most effective treatment for overactivity, but it's the most invasive. And to be honest, there's relatively few men who feel that their symptoms are so bad, they want to progress to this. But if life was terrible, if you were leaking all the time in nappies and it wasn't related to sphincter weakness, stress incontinence, it was related to overactivity, then this is definitely an option, and it's an effective option, but it comes at a cost. That's an artificial urinary sphincter, and that's to treat stress incontinence. So if you have had your prostate out and the muscle that keeps you dry is damaged, then your main issue will be that when you move, when you exercise, you leak urine, and that it often gets worse towards the end of the day. You're often much drier at night. And so the 3-piece bit of kit, the artificial urinary sphincter or a male sling, may be the answer for you, but it's not a treatment for frequency, urgency, urge incontinence due to the overactive bladder. It's a treatment for stress incontinence due to weakness of the sphincter muscle, the muscle that keeps you dry, that sits at the base of the prostate at the top of the water pipe.
Yeah. And have we covered everything then?
Well, if you were miserable with your frequency, urgency, urge incontinence, but you didn't think a clam was for you, the final options that you could consider are to form an ileal conduit, which is where you detach the pipes that drain the kidneys from the bladder, you plumb them into the back of a sausage of bowel, and you bring it out onto the skin so it drains into a bag. That's called an ileal conduit. Again, that would be pretty rare that a man after prostate cancer treatment would have such problematic frequency urgency that they would need that. And the final thing is you could just have a catheter put in. So the same sort of tube that drains your bladder after you have the prostate operation, you can have that put back in. You can have it put back in up the water pipe, or you can have it put back in through the tummy directly into the bladder, what we call a suprapubic catheter, and just keep that on free drainage if it just is too much for you. So those are the sort of bailout options. But I would say that in my centre, we do about 700 radical prostatectomies per year. And we probably see about 5% of them with significant stress incontinence wanting the sphincter or sling, and maybe about 5 men a year with disabling frequency urgency, and maybe another 5 to 10 with frequency urgency related to their radiotherapy treatment. And maybe 1 man in 5 years has asked for the clam or the ileal conduit. It's very rare that you get such a significant problem that you would fail all the other more conservative treatments. So you should take heart. Thank you very much. It's been a pleasure.